Hello friends, now I'll be discussing AIIMS November 2019 recall medicine questions. Well, first of all is the match the following. In this case, anti-GO1 antibody, they are seen in dermatomyositis, that is C. Anti-topoisomerase, this is D, this is seen in systemic sclerosis. Anti-U1 RNP antibody, this is B, that is mixed connective tissue disorder. And anti-Smith antibody, they are seen in SLE. But let's learn something more about various antibodies. Well, as I told you, that anti-topoisomerase is seen in systemic sclerosis. But in systemic sclerosis, we also see anti-SCL 70 antibodies. Similarly, anti-centromere antibodies, they are seen in CREST syndrome. Well, in SLE, anti-Smith antibody, but we also write as anti-SM antibodies. They are specific antibodies in SLE. Now, other specific antibody in SLE is anti-double-stranded DNA antibodies. But the most sensitive test for SLE is anti-ANA, anti-nuclear antibodies is the most sensitive test for SLE. Okay. Let's discuss question number 2. 34-year-old male, he has palpitation, heart rate very fast. His BP is 70/40. They are the key words that we have to see. And he has already been done the vagal maneuver and adenosine. What the next step? Well, if you look into ECG, he is a classical ECG finding of PAT, paroxysmal atrial tachycardia. And in such cases, the first thing is we try our increase vagal tone by vagal maneuver. Okay, that is carotid sinus massage. Okay, this to increase the vagal tone, which may stop PAT. If not, then we try adenosine. Adenosine is a very fast-acting drug. Okay, that can break PAT, that can convert PA into normal sinus rhythm, but they have failed. And moreover, patient BP is very low. That is, he is hemodynamically not stable. He is hemodynamically unstable. What is the meaning of hemodynamic stability? That means the patient systolic BP should be above 90. But here the systolic BP is just 70. That means that means he is not hemodynamically stable. Now we can't take a chance. If we do not treat properly, he may have a cardiac arrest any moment. So in such cases, the best answer is direct DC cardioversion. This is the best choice. Why not repeat adenosine? We cannot take chances because he's already systolic BP is already 70. Adrenaline has no role in the treatment of PAT. And amiodarone, this is not used in acute cases, especially in such cases. Amiodarone is usually we can use as a prophylactic drug so that recurrence of PAT doesn't occur. But definitely, and moreover, I hope you know that amiodarone is a very slow-acting drug, and it has a very long incubation period. It's a long duration of action also. That's why amiodarone is not used. This the C is the best answer. Well, this one question. But before I proceed further, I'm very happy to say that 95% question what I'm discussing today, everything has come from my Medicine e-Gurukul app. Everything I have discussed. Those of you who have seen my Medicine e-Gurukul app, you will find everything is there from that app only. Again, this one graph, which in all my classes I tell that in AIIMS exam you always get one question from serology of hepatitis B. Well, what is this? If you look into this diagram, this is the surface antigen. This is the E antigen. This is the hepatitis B virus core antibody, IgM. Okay, IgM. Well, answer is anti-hepatitis C. In fact, since it's a memory-based question, we got the question like this. The better option would have been IgM antibodies. These are the IgG core antibodies, IgG core antibody, which usually tend to rise only after 6 months. Okay. Well, this surface antibody, they usually appear like this. They come after 6 months. This is surface antibody. And anti-E, again, this somewhere it rises like this. This is E antibody. E antibody usually, of course, they usually start rising maybe before or somewhere around near 6 months they start rising, right? Now, few extra points that you got to know. What is the best epidemiological marker for surface antigen is the best epidemiological marker for hepatitis B. That means if it is not there, then it's not a case of hepatitis B. Earliest to appear, again, surface antigen. Best marker of infectivity, E antigen. That means patient infective or non-infective is determined by E antibody, E antigen. If E antibodies are there, that means the patient is non-infective. And IgM core antibody, they are the marker of acute infection. And IgG core antibody, they are the marker of chronic infection. Okay, right? And surface antibody, they are present in those patients who have been only vaccinated. In vaccinated person, only surface antibody will be there. And presence of surface antibody, suppose in one patient there is only surface antibody is there, that patient is safe for blood transfusion. That means he can very well donate the blood for transfusion. Okay. Question number 4. This question I discuss in all my classes. Those who have attended my class, this question is there. Okay. And of course, this is there in my Medicine e-Gurukul app also. What is this? This answer is HAGMA. HAGMA stands for high anion gap metabolic acidosis. Well, with metabolic alkalosis, that means this is one condition. Patient has metabolic acidosis with metabolic alkalosis. How do you know? pH is normal, 7.40. Now, if you calculate the anion gap, how we calculate anion gap? Sodium minus chloride plus bicarbonate, 145 minus 124. This comes out to be 21. The anion gap here is 21. The normal anion gap is about 6 to 12. So, although pH is normal, but anion gap is increased, and this is seen in one condition where patient has metabolic acidosis with metabolic alkalosis. And this is classically seen in chronic kidney disease with persistent vomiting. Due to chronic kidney disease, patient has high anion gap metabolic acidosis, and due to vomiting, patient has alkalosis. In fact, this question came in last year, November 2018 also this question came. It's a repeat question, and of course, this is there in all my class tests as well as in medicine e-Gurukul app also. Can it be metabolic acidosis? No way. pH is 7.40. This cannot be. Okay, and moreover, bicarb is normal. This cannot be metabolic acidosis. Normal ABG, no. Anion gap is increased. This is not normal. Respiratory acidosis, this cannot be, because in fact there is nothing mentioned about CO2, and moreover pH is normal. This cannot be respiratory acidosis also. Okay, lovely question. It's a repeat question from AIIMS, but it is there in all my class tests also. Now let's discuss question number 5. Drug not given in Wilson disease is calcium citrate. Now, as we know very well, Wilson disease is an autosomal recessive disorder, and we also know it's a disorder of copper metabolism, and the excess of copper is get deposited in the liver, lead to chronic liver disease. It can even lead to cirrhosis of liver also. Excess of copper also get deposited in the basal ganglia, and that lead to Parkinson-like feature. And in the eyes, it can lead to KF ring. And excess of copper is deposited in the Descemet membrane. Okay. Now we have to use certain drug, either they chelate the copper or they reduce absorption of copper. So we use trientine, we use penicillamine, and we zinc. Calcium citrate has no role to play in the treatment of Wilson disease. And how to diagnose the case of Wilson disease? Of course, in this case, there is reduced level of serum ceruloplasmin level. But the most accurate test is you go for liver biopsy, and in the liver biopsy you look for the copper content, and copper content is increased in this case. That's the diagnostic or most confirmatory test for Wilson disease. Now, question number 6. Cornerstone of treatment of dengue fever with warning sign without shock or hemorrhage is, answer is IV fluid. This answer is a bit easy. Why? Let's see. What about platelet transfusion? Definitely is not an indication. We can very easily rule out. Steroid have no role to play in dengue fever. Ribavirin again has no role to play in the treatment. So easily we have ruled out 3. So beyond doubt, the answer remains is the IV fluid. Okay, ribavirin we use in hepatitis C, viral infection. Although we have much better drugs now, so as of now we have easily ruled out a 3. That the only option left is IV fluid. Why it is the best answer? Of course, one of the basic pathophysiology of dengue fever is increased capillary leakage. That means the capillary fluid tend to come out. When the water goes out of the capillary, that lead to hemoconcentration. That is the reason why they have an increased hematocrit. Okay, so that's why the first line or treatment is always use IV fluid. And one more thing, the patient has very high grade fever, use paracetamol because in these patients tend to have low level of platelet, which can lead to bleeding tendencies. So in such cases, a drug like aspirin are never used because that can add to the antiplatelet activity and that can have increased bleeding tendency. So now you are convinced the answer of this question is IV fluid only. Question number 7. A 52-year-old man was the known case of COPD and he has come to you. What is your diagnosis? If you look into this ECG, okay, you look at in various P waves, P waves, all have different shape. The answer of this question is multifocal atrial tachycardia. MAT stands for multi, multifocal atrial tachycardia. It's again a repeat question. It had come in the last AIIMS exam also. So for whatever others, since P wave is there, so this cannot be atrial fibrillation. PSVT, the P waves have a normal, same shape is there. Here it is different, this cannot be PSVT. Sinus tachycardia cannot be there because again the main thing is a P wave has different shape. So multifocal atrial tachycardia is the answer in this question. It's a repeat question. Okay, but of course if the P wave was not there, then the answer would have been atrial fibrillation. Now if I tell you there are 4 important causes of atrial fibrillation. But atrial fibrillation, number 1, 4 major causes are rheumatic heart disease, coronary artery disease, hypertension, and hyperthyroid. They are the 4 most common causes of atrial fibrillation. But in addition, point to be noted, AF can occur in a normal person also. It can occur in a normal person, especially after tea, coffee, and alcohol. And that's why AF is also very popularly known as holiday heart syndrome. Holiday heart syndrome especially occurs in the weekend when the a person take very heavy dose of alcohol, and that can induce atrial fibrillation, what we call as holiday heart syndrome. Question number 8, the preferred diet in the end stage renal disease. We want high calorie and low volume. Why it is the answer? First of all, why we want low volume? Because patient has kidney failure. So patient tend to retain fluid. Okay? Because so patient tend to have retained fluid, so that can lead, if the person take high amount of fluid, that can lead to volume overload, which we don't want. We want to give high calories because in this patient has anorexia. That's why in these cases various deficiencies are very common. Okay, so we want to give high calorie diet, and because of anorexia, patient has got fatigue also. So high calorie and low volume diet is the answer, right? This is again a question from my app only, and this same picture is there in my app also. Well, patient has eclampsia and patient had palpitation, respiratory distress. This is a classical ECG of Torsades pointis. Okay. Exactly same picture is in my app and of course in my book also. Answer is magnesium sulfate. Now we all know Torsades pointis is due to increased QT interval. Okay. Now let's learn what are the causes of prolonged QT interval. Prolonged QT interval, the most common cause is hypokalemia. It can occur in hypocalcemia, hypomagnesemia, class 1A antiarrhythmic drug. It can also occur in by use of erythromycin. Okay, there are the few causes of prolonged QT interval which can induce to which can lead to this type of arrhythmia, so-called Torsades pointis. In Torsades pointis, the best initial treatment is always magnesium sulfate. It should be done very quickly, otherwise patient can go into ventricular fibrillation and patient can have cardiac arrest. Okay, DC shock is not given in such patient. This is never the first choice. And calcium level has got, again, not to be given. There is no immediate role in the treatment of Torsades pointis, although hypocalcemia does lead to Torsades point, but it's never the first line treatment. Amidon has no role to play in the immediate treatment of Torsades pointis. And most of the time, hypokalemia is, in actual practice, hypokalemia is the most common cause. So once we have given magnesium sulfate, in the meantime, serum potassium level are checked, and if potassium is reduced, then you have to infuse potassium. And if the offending agent is a drug of class 1A, class 1A drug include like procainamide, okay, or quinidine. If any of these drug patient is already taking, then withhold the drug is the answer, but nothing to beat. The immediate treatment is magnesium sulfate. Well, renopulmonary syndrome include all the following except answer is cirrhosis liver. Now let's learn the basic concept. What do you mean by renopulmonary syndrome? There are certain diseases where there is involvement of kidneys as well as lungs, and they are what we call as renopulmonary syndrome. Like in good posture syndrome, patient has renal failure with hemoptysis. Same thing happen in leptospirosis also, patient has renal and as well as kidney involvement. Hantavirus also can have this problem. In cirrhosis liver, we have a hepatopulmonary syndrome. Hepatopulmonary syndrome. We also have a hepatorenal syndrome. Okay, but we don't have renopulmonary syndrome in a case of cirrhosis liver. Just to add on to you, hepatopulmonary syndrome, renopulmonary syndrome, this can also occur in vaginous granulomatosis. Okay, but out of all the options, one option where renopulmonary syndrome does not occur is cirrhosis of liver. Hypercalcemia due to vitamin D can be treated with prednisolone. And if you look into other option, in fact, when we talk about treatment of hypercalcemia, in acute cases, what we use? The acute cases we use, we give normal saline, plus we give intravenous furosemide. And in chronic cases, we use biphosphonate, and we used prednisolone, okay. Now look into the option. Hydrochloroquine, chloroquine, hydrochloroquine and ketoconazole, they are nowhere we use in hypercalcemia. This is the only drug that we use, especially due to vitamin D intoxication is a very good drug to treat hypercalcemia. Okay, now hydroxychloroquine. Now stop the video, write down the answer. Tell me in which endocrine condition we are using hydroxychloroquine. Stop the video, write down the answer. Okay. Similarly, other question is in ketoconazole we use in which endocrine conditions? Two questions are there. Well, I'm sure you have written the answer. Answer is hydroxychloroquine. The latest treatment is, it is added or treatment in diabetes mellitus type 2. It's a recently approved drug. And ketoconazole is an antifungal drug, but we use in symptomatic treatment of Cushing syndrome. Cushing syndrome, okay. Question 12, post-operative thromboprophylaxis is given subcutaneously. Now first of all, why we want to give this prophylactic drug with low molecular weight heparin? This is to prevent deep vein thrombosis. Because post-operatively patient remain for prolonged bed rest. Prolonged bed rest predisposes to deep vein thrombus. Of course, the best prophylactic treatment is always passive leg exercises. Or what we can say, early ambulation. That means let the patient walk depending on how the clinical condition. But still, if the clinician find the patient's we cannot ambulate, then the prophylaxis we always give low molecular weight heparin, but it is to be given subcutaneous. Idea is to prevent deep vein thrombosis, otherwise that can lead to pulmonary embolism. Now one more question for you. Suppose the patient develops pulmonary embolism. Of course, 70% cases pulmonary embolism are no symptom. Now stop the video, write down the answer. What is the most common presenting feature of pulmonary embolism? Well, I'm sure your written answer. Answer is sudden onset of dyspnea. Is the most common presentation of pulmonary embolism. In addition to that, patient can have pain chest. Patient can have hemoptysis. Patient can have acute right heart failure. Patient can have syncope. And of course, patient can have death also. So they are the presentation of acute pulmonary embolism. Well, beautiful question. 16-year-old boy, cough, pain, fever, sore throat, CPK level is high. The answer is viral myositis. Most of the social media, they have given answer as dermatopolymyositis. It's wrong. It's not the answer. Why? Why viral myositis? It is patient has got typical classical history of fever, sore throat for 5 days, and cough, pain, tenderness is there. Okay, and CPK level high. So there's no doubt about the case, the diagnosis of viral myositis. Now let's look into other option. This Duchenne muscle dystrophy, it doesn't present in 5 days. It's a congenital disorder. And usually patients are young, 5 to 7 years, and they don't have presentation like this. What about Guillain-Barré syndrome? In this case, remember, normal deep tendon reflexes, the GBS, DTR are diminished. Moreover, they do not manifest with pain, because they usually manifest with weakness. So this is not possible. Dermatomyositis, they don't come with the 5 days. And moreover, in such cases, skin rash is a very important finding. Of course, these two are the close differential diagnosis, but out of these, viral myositis is the answer, because this patient has developed fever, sore throat, and cough tenderness. That's the best answer. Moreover, in dermatopolymyositis, in myositis, proximal muscle weakness is the main problem. Okay, again, pain tenderness is not that common as compared to viral myositis. Hence, the best answer is viral myositis. Now, CPK level are increased in dermatomyositis as well as viral myositis. Question number 14 is beautiful question. Again, from my app only. Answer of this question is mineralocorticoid. Although social media, what you have reading, they have given answer as estradiol. Estradiol is the most common wrong answer. Why it is the answer? This can be answered by those whose basic concepts are very, very clear. So let's learn the basic concept. Well, if you look into this, glucocorticoid is secreted by adrenal gland. It is under influence of ACTH, this one. Levothyroxine under TSH. Estradiol under this control. But it's this molecule, so-called aldosterone. Aldosterone is under control of renin angiotensin system. Okay, renin angiotensin aldosterone system. It's not under control of pituitary gland. So this level will not be, that means aldosterone level will not be affected much. Okay, so we have to give, so that's why we have to give replacement of glucocorticoid, levothyroxine, T3 and estradiol replacement has to be given. But we don't need, because that aldosterone is not under control of pituitary. Okay, I hope things are clear to you. 15, again one more question from dengue fever. If you look into this again, you can diagnose the answer is this. Why? Now urine output more than 200 ml. That means if the patient has urine output of 300 ml, will you discharge? No way. Patient is still under renal failure. Remember, oliguria means urine output less than 400. The patient has urine output of 300, still patient is oliguric, still patient has pre-renal failure. That's not an indication of discharge. Patient need more IV fluid. Fever control with paracetamol for more than 24 hours. No way. Fever is not the criteria of discharge. And return of appetite, no way, they are not indication. Yes, the patient is has recovered from shock for more than 24 hours, and we presume by the time patient is taking adequate oral fluid also, then we can definitely think of discharge. So again, the previous question what we came with dengue fever, we got another feature of question of dengue fever. By rule out technique only we can very well say this is the best answer. And we know very well in dengue fever, patient can go into hypovolemic shock, and the mainstay of treatment is intravenous fluid. Stop. Question number 16. Pegloticase is used in treatment of chronic gout. It's a new drug. Okay, so let's talk about what are the newer drugs that we have got for gout. The new drug for gout are number 1, benzbromaron. Benzbromaron is a uricose-uric drug. Then we have febuxostat. This is a xanthine oxidase inhibitor, just like allopurinol. Then we have got 3 drugs which have a uricose-uric action: amlodipine, fenofibrate, and losartan. These 3 drugs have uricose-uric action. Now, losartan, of course, is a ARB which has got uricose-uric action. Now, stop the video, write down the answer. I have some question for you. Well, the question comes, which the only ARB with that we use in gout is losartan. The question is, which ARB we should use in diabetes? Which ARB we should use in migraine? And which ARB is fat soluble? Okay, well, I'm sure you have written the answer by now. The answer is telmisartan. Telmisartan. Because this telmisartan acts on the PPAR gamma receptor. Migraine we use candesartan. And fat soluble is valsartan. They are very, very important questions. Now, incorrect regarding obtaining AB sample, answer is C. Why this? Because if you 0.5 ml is a huge amount of, and if you use it, it is definitely going to dilute the sample. We simply rinse this syringe. Rinsing means you just push into the vial some air, suck out the heparin. Again you make it empty. That means just rinsing of syringe is needed, not 0.5 ml. Hence it's the best answer. Okay. Now, AB sample, normal pH cannot rule out acid-base disorder. I think this question we discussed previously. We got one patient of CKD with vomiting. There was apparently normal pH, but remember anion gap was increased. So of course that doesn't rule out acid-base. This I discussed in great detail, so no need to discuss again. Choose an alternative site if LN test is abnormal. It's not that necessary. Radial artery is a preferred site. Well, this can be taken from femoral also. Out of the all option, this is the best option. Okay, radial artery we can use. It's not a bad answer, but definitely remember in the exam, examiner never say choose the right answer. He say choose the most appropriate answer. This is the most appropriate answer out of all the other 3. All the following are used in the heart failure. Answer is timidrazine. Sacubitril. In all my classes, even in vibe also, I said you will surely getting question on sacubitril. Well, this is again from my app. Nesitride is the drug that is the ANP analog. This I discussed in my vibe visual image based session also. I discuss vibe also. Nesitride is a BNP analog, is a ANP analog. We use in CHF. Metoprolol we use to control heart rate. Sacubitril we use in the heart failure. This is used in coronary artery disease. Okay. Now, why we use metoprolol? This is to control heart rate. To control heart rate. More the heart rate, more is the oxygen demand. So we use. What are the beta blocker which can be used which in heart failure? We can use metoprolol. We can use bisoprolol. Okay. And we can use carvedilol. What is the special precaution you will take when we use beta blocker? They should always be used in the lowest possible dose. Never start with the optimum dose and gradually increase. That's the way the beta blocker should be used in congestive heart failure. Okay. And as far as sacubitril concerned, it's a neprilysin inhibitor. In that way, it will prolong the action of ANP, and ANP will lead to more and more natriuresis. Now, an elderly man with massive hemorrhage, stroke and coma need early intubation? Yes. This statement is true because most of the time they are unconscious and they need a ventilator therapy, especially when he is deep coma. Half of the patient after stroke develop sleep apnea. No, this is not the correct answer. So in this case, statement A is correct, but B is definitely wrong. The answer is exertion is independent true. No. Exertion is independently true. A correct statement, but the reason is independently false. Yes. The answer is C. Okay. Now, I have one question for you. Suppose the patient has stroke come to you. Stop the video, write down the answer. And I asked you to do one investigation. What shall be your first investigation of choice in any case of stroke? Well, the answer of this question is, the right answer is plain CT scan. Is always the first investigation of choice. And one more thing, the first 24 hours, plain CT scan in ischemic stroke will be normal. Then why we are doing? We know very well that ischemic stroke, CT will be normal, but we do it to rule out bleeding. Because bleeding is best picked up by CT scan as compared to MRI, especially for the first 24 hours. So first of all, we do CT scan not to pick up ischemic stroke, but to rule out bleeding or hemorrhage. MRI is not a good investigation in early first 24 hours. Addison disease is seen in autoimmune adrenalitis. Let's look into other option. ACTH producing tumor, they lead to Cushing syndrome. They do not lead to Addison disease. Cushing syndrome again due to increased steroid, not Addison disease. Hypopituitarism lead to secondary hypoadrenalism. Addison disease is a primary hypoadrenalism, and that is the most common cause. It routinely is autoimmune. But remember, in India, in our country, the answer is tuberculosis. And one more thing, very, very important point. The commonest endocrine organ to be involved in HIV is again adrenal gland, and that can lead to hypoadrenalism. Okay. So answer, straight easy question, answer is A. Now I'll be discussing question 21 regarding vasopressin escape. Now before I discuss this question, let me tell you what is the mechanism of hyponatremia in SIADH. We all know very well that the characteristic feature of SIADH is hyponatremia. Okay. So once we understand the basic concept, then this thing will be very easy to understand escape. Now, this is the let me give you example. Now this is a glass. It has 100 ml of water, and it has 100 milligram of salt also. That means the concentration of the salt in this glass is 1 milligram per ml. Okay. Now if I add 100 ml water more, the volume becomes 200. The concentration of salt now is how much? 0.5 milligram per ml. But point to be noted, still in this glass, the amount of salt is same, that is 100 milligram. Now the concentration from 1 to 0.5 it has gone. It's not due to sodium problem, but due to excess of water. Exactly same thing happened in SIADH also. Now what happened in SIADH? This is the nephron. And we all know very well that ADH acts on the distal convoluted tubule DCT, and it is via aquaporin receptors, and it only absorbs water. ADH has got no role in absorption of sodium or potassium. Now the normal plasma osmolality is between 280 to 300 milliosmol per liter. When the plasma osmolality comes to 280, the amount of ADH secretion is highly reduced, no water reabsorption. But if the osmolality goes to around 300, more and more ADH and more water reabsorption. That means ADH is being controlled by the plasma osmolality. Now, at time, the plasma osmolality has gone to 280, and in this situation, we don't need any ADH. But still, body keeps on secreting ADH. That means more and more water reabsorption. More and more water into the body, that lead to what? Hyponatremia. Exactly the same what happened in this glass. More and more water coming in, sodium concentration as well as plasma osmolality goes down. But remember, in SIADH, ADH level is always very high. It means, is it true that water will be keep on absorbing all the time? Well, to a certain limit. To a certain limit, water is absorbed. ADH level is high, that is vasopressin level is high, but still after some time the plasma osmolality has gone to a limit. Now this receptor will stop responding to ADH. Stop responding to ADH although the ADH level is very high, and this is known as vasopressin escape. So despite high amount of ADH, now that there is down regulation of aquaporin 2 receptor, and now water will not be absorbed, and suddenly there will be polyuria. Polyuria will be occur because of sudden down regulation of aquaporin 2. And now I hope you understood the meaning of vasopressin escape phenomena. Question 22. All are true about bone marrow biopsy except, well, this can be done in both prone or lateral position. Although mostly we do in the prone position, but if there is some problem in lateral position, it can be done. Can be diagnosed to infiltrated glomerular disease? Definitely it is done. Of course, this can be done to diagnose leukemias also. Breath holding during the procedure is not required. Is contraindication? No. Is below 40,000 is not a contraindication. You can very well do in platelet count of 35,000 also. Hence, this is the best answer in this case. complication of massive transfusion. Of course, both these can happen, but this is a better answer. Why is it so? Because when we give transfusion, large amount of citrate also goes into the body, and this citrate get converted into bicarbonate, and that lead to metabolic alkalosis. Okay. Now, what are the other complications, especially related to electrolyte, which can happen in massive blood transfusion? There can be hypocalcemia, there can be hypomagnesemia, and now something very interestingly, there can be hypokalemia, there can be hyperkalemia. This you need to understand why will happen. Why hyperkalemia will happen? Because stored blood, we all know very well, this is the RBC, and potassium is mainly an intracellular ion. In the stored blood, this potassium goes out. So when we do the massive transfusion, large amount of potassium, which is extracellular, goes, and that can lead to hyperkalemia. But how can hypokalemia? Just now I told you, when we are giving blood transfusion, we are giving citrate, and that lead to metabolic alkalosis. And that due to metabolic alkalosis, potassium tend to go into the cell, so hypokalemia can happen. So either of the thing can happen depending on how much amount of blood is given and how fast the blood is being given. So these are some of the problem which related to electrolyte and acid-base disturbance due to high blood transfusion. Which of the following is the manifestation of inhaled anthraxins? This is a good question, but there is some confusion. In fact, this can lead to pneumonias, it can lead to, okay, but this is the classical finding. This is the best answer. Pneumonias can happen, but abscess formation is not a classical problem. Okay, since it's a memory based question, the question would have been better if all the following can happen except, then beyond, this was the best answer. But as of now, whatever question we got it, because we as a faculty have not appeared for the exam, it is student have appeared, and whatever question you are given, we are to answer that. If this question come, then hemorrhagic medicine is the best answer of this question. Okay, and of course, extra edge question that you got to remember, you get malignant pustule in this patient. In case of anthrax. Okay. Now, this question. In community acquired pneumonia, we give a combination of beta-lactam, beta-lactamase inhibitor, and azithromycin. This statement is absolutely true. It covers all the common organisms, including endocrine. This is also true. Answer is A. Now, let me discuss in more detail. What are the common organisms that we cause community acquired pneumonia? CAP is community acquired pneumonia. This is caused by strep pneumonia. It's caused by Haemophilus influenza. This can, okay, and then in fact, this is the most common cause of community acquired pneumonias. Well, which the most common organism for hospital acquired pneumonia is gram-negative bacilli. The most common organism causing pneumonias in the ventilator. This is by Pseudomonas. So when we are admitting a patient with community acquired pneumonia, we use this because this covers all the organisms, including anaerobes also. Hence, this is the best answer in this case. Question 26. Regarding peripheral smear, it shows eosinophilia. No, it does not lead to eosinophilia. It's not a classical finding. But lead poisoning definitely inhibit several enzymes in the heme biosynthesis. So this is correct. So in this way, assertion is false, but reason independently is true. This is the best answer. Reason is true, but assertion is wrong. Now let me tell you what are the other things that can happen with lead poisoning, especially related to blood. It can lead to sideroblastic anemia. Number two, it can also lead to punctate basophilia. This is a classical finding. Basophilia. And it can lead to hemolytic anemia. And of course, I told you it lead to reduce or inhibit hemoglobin synthesis also. Question 27. Hepcidin inhibit function of ferroportin. Now, hepcidin is increased in condition like anemia of chronic disease. And it causes, ultimately it is the hepcidin molecule which reduces hemoglobin level by two mechanisms. First of all, it potentiates ferroportin. And ferroportin is the one which absorbs iron in the intestine. Now, if that inhibit the function of ferroportin, so that lead to reduce iron reabsorption from the GIT. Other effect of hepcidin is it also reduces iron mobilization from the cells of reticuloendothelial system. So the ultimate result will be there will be reduced serum iron. Okay, reduced serum iron. But one more thing that you got to know in these cases, iron ferritin level is very high, because effect of hepcidin is more in iron mobilization. It reduces iron remobilization. Of course, I told you it does affect ferritin, but not that much. So, but effect of reduced iron mobilization, although iron is slightly less than the normal, but still whatever is coming, it is being in the store, it is in the blood store, not being utilized. So in due course of time, there is increased serum ferritin, but store is full, but reduced mobilization. That's why initially we get normocytic normochromic anemia. Later on we may get microcytic hypochromic anemia. Okay, microcytic hypochromic anemia. The answer is ferroportin. Match the following. Well, if you had to look into this, omalizumab is IgE. That's why we use in the case of bronchial asthma. Belimumab is anti-3-BFAP, and this we use in asthma, and this we use in SLE. This we use in SLE. Daclizumab, this is anti-CD25 drug, and that we use in multiple sclerosis. And itolizumab is anti-CD6. There are new drugs that we use for psoriasis. Okay. In addition, I definitely like to mention something extra for you: secukinumab. This is very effective in ankylosing spondylitis, again for psoriatic. Question 29. The most common infection after a solid organ transplantation is cytomegalovirus. It's the most common. Okay. Now, in fact, after bone marrow transplantation also, this is the most common organism that is affected. And this usually, especially after bone marrow transplantation, 7 to 12 weeks after bone marrow transplantation. And Epstein-Barr virus is especially not a problem in bone marrow transplantation. Herpes simplex does occur, but it occurs within 0 to 4 weeks after bone marrow transplantation. If it occurs, then you have to treat by acyclovir. Then varicella zoster, again infection in bone marrow transplantation, to be more particular, it occurs usually after 13 weeks, and we treat by again acyclovir. And for CMV, we treat by genciclovir. Question 30. Well, in this we are getting hemophilia given blood transfusion, and he get hypotension, breathless, okay, depression, pneumonia-like picture we are getting. This is the classical finding that we get with trolley. Okay, now what is the full form of trolley? It's transfusion related acute lung injury. After blood transfusion, patient develop picture mimic like pneumonias or ARDS. ARDS, that is non-cardiogenic pulmonary edema. Sudden onset, patient may classical picture just resemble like bilateral bat wing appearance, and patient may even develop hypotension, capitation also. And this is trolley. What about this is the non-hemolytic febrile reaction. That what we again patient develop fever in this case. Fever due to non-hemolytic febrile reaction, what we call as fever, but though there is no hemolytic reaction. Transfusion reaction that we definitely see with mismatch, and of course some certain infection can also be transmitted, but they never happen suddenly. Okay, sepsis can never happen immediately, and the immediate transfusion, the best answer is trolley. Is a very dangerous condition. It carries if not treated promptly, it carries a very high mortality. Well, it's a question from microbiology. Is testing done for all except mucormycosis? Straightforward question, microbiology question. 23-valent pneumococcal is most useful in sickle cell anemia. Why? Let's learn the basic. Now, after sickle cell anemia, these patients are in sickle cell anemia. First of all, autosplenectomy occurs. And that's why sickle cell anemia are very prone to infection by encapsulated organism like pneumococcus. Okay, like H. influenzae, right? And of course, Neisseria meningitidis. So that's why whether patient has done splenectomy has been done due to any reason, maybe hereditary spherocytosis, or like in sickle cell anemia where autosplenectomy occur. This 23 poly vaccine is very, very important, very useful. Otherwise, these patients are those who have spleen has been moved either due to sickle cell or due to surgical procedure. These patients are very prone to infection by the encapsulated organism. Match the following. Again, Burkitt lymphoma is 2, that is 814. Follicular lymphoma is 1, that is 1418. Mantle cell is 4, 1114, and marginal zone is 3. Right? Now let me tell you certain more this translocation in various diseases. In M3 variety of AML, classically we get T1517. ALL, you also get T411. And in CML, of course, we get 922. And it is CML, I think everybody knows this is Philadelphia chromosome. Okay, now I have a question for you. Stop the video, write down the answer. There are two questions. First of all, in what percentage of cases of CML we get Philadelphia chromosome? Second question is, in other than CML, in which other condition you get Philadelphia chromosome? There are two questions. So you can stop the video and write down the answer. Well, I'm sure you have written the answer. Answer is in CML, it is there in around 95% cases. And other condition where the Philadelphia chromosome is ALL. Point to be, it is CML, myeloid leukemia. It is acute lymphocytic leukemia. In around 5% case of ALL, Philadelphia chromosome is present. And presence of ALL in Philadelphia chromosome carries a poor prognosis. Now, we have another question to talk about. Match the following. In which condition we see this type of picture? Well, this is what we see in osteogenic imperfecta. This is hyperextensibility of the joint. This we see in Marfan syndrome. This is clipal field abnormality, so-called spheringeal shoulder. Is a congenital dislocation disorder. Here the one shoulder is height is more than the other shoulder. And this question is capsuloid spot, and this question come almost every year. This is what we see in neurofibromatosis. Okay, now let's see what are other findings that we see in neurofibromatosis. In neurofibromatosis, we see iris Lisch nodule. In NF1, we also get axillary freckling or inguinal freckling. We also get optic glioma. We also get neurofibroma. All these we get in NF1. But in NF2, classically we get acoustic neuromas. Okay. Question 35. Regarding all are true except this is true. It has got polygenic inheritance. Laboratory gene decreases the incidence, yes. Benzodiazepine alone cannot treat, yes. Valproate should be no, this is wrong. Valproate is one of the drug of choice. So in fact, the valproate is very effective in treating these cases. Okay, now regarding myoclonus, it is seen more in children. It is a shock-like, sudden shock-like, like this, shock-like, sudden shock-like. And classically, it occurs in the early morning when the patient gets up in the morning. And something very interesting, this myoclonus can occur in a normal person also. Normal person also. Quite possible that it must have happened with you also, or you may not have noticed. You get up in the morning, suddenly you find a jerk like one limb, one half of the body, or the whole body, you get a jerk like this. So what I want to convey the message, this can be seen in a normal person also. As I told you earlier, it must have happened with you, but you may not have noticed. But next time when it happens, you will definitely notice it. At that time, तब आपको मेरी याद तो आएगी that Dr. Bhatia told us about this. Nothing worry about it. What I said was that time you will definitely go to think about me that Dr. Bhatia told that this may happen in a normal person also. Well, the right answer is valproate should be avoided. Not correct. It is one of the drug of choice for these patients. Now, SSPE. that is subacute sclerosing panencephalitis. Subacute sclerosing panencephalitis. Now, true, false. Characterized by seizure, personality change, dementia, myoclonus. Yes. It occurred due to herpes simplex. No, this occurred due to measles. Measles. So this statement is incorrect. E.g. characteristic shows periodic sharp waves. In fact, is some typing error is there. The double typing is there. So you can write down pattern of show periodic shows pattern of burst BUR burst every 3 to 7 seconds followed by flat background. Pattern of burst every 3 to 7 seconds followed by flat. What I mean to say, like burst is there, but again flat, again burst. So this whatever that spike come periodic, this is known as burst, and the flat period is known as burst suppression. This is burst suppression is there. This is correct. Usually 7 to 12 hours, yes, after years after. So what we can say is a slow virus disease. That's why it's a part of slow virus disease. This is correct. May be normal. This is also correct. It may at time it may not be there. Not necessarily it may be there. Okay. So friends, these are all about medicine questions. And one more thing, I'm very happy to say, more than 95% questions have come from my Android, my Medicine e-Gurukul. Those who have seen my Medicine e-Gurukul, I think they must have been able to solve almost all the questions. Okay, so you can also get this this thing e-Gurukul from our app, DBMCI app. To get it, visit our website www.dbmci.com, dbmci.com. dbmci.com. You can even call at this number during the working Monday to Saturday in the working 10 to 7. Okay. And when you go to this, look for the Medicine e-Gurukul by Dr. Mukesh Bhatia. This is Mini Harrison. It's available on Amazon. Okay. I hope you learned a lot of the new thing with this discussion. Thank you very much for watching this video.